And so, after the evolution of ACT in the say 70s and 1980s, probably the most significant next development was the greater articulation of the role of the case manager in terms of being a person who both had a relationship with the client, but also began to take a more positive and a more rehabilitation approach to improving functioning. And this is what is best characterized as the strengths model, as described by Charlie Rapp and his colleagues at the University of Kansas. And the idea of the strengths model is that rather than focusing exclusively on deficits and the remediation of deficits, which is not thought to be unimportant, but that there was an over-focus on pathology and not enough of a focus on helping people develop skills, and not enough of a focus on using natural supports that were present in the environment or could be tapped. So the nature of the strengths model of case management is that it's focused on building on individual strengths. It sees the relationship as critical, but also borrowed certain parts from ACT so that the majority of services are provided typically, when possible, in the community as opposed to at the clinic. It also looks at the environment as, rather than it being a set of different obstacles to integration, as actually containing a wide range of resources. And so the idea of the case manager doing the strengths model is to help the client tap those resources and help the person find those natural supports, those living situations, those jobs, and so on and so forth, where they can fit in and make a real contribution. And this is sometimes called a model, but not always called a model, is a rehabilitation model of case management, which is kind of similar to the strengths model, but also tends to incorporate the more active teaching of skills and the like. The idea being that a critical function of case management is the identification of client goals, to provide services in the community, to either directly provide or to link people to rehabilitation type services designed to help people develop skills necessary to achieve their goals. And I'd say that's where we're at right now. The system's varying anywhere from clinical case management to strengths-based or rehabilitation case management, with many systems, but not all, having the capacity to deliver ACT services to a subgroup of people. So let's get into talking about what is ACT and just a little bit more about the history. Well, I mentioned the very first ACT study in the early 70s was aimed at seeing if people with severe mental illnesses could be maintained, if they could live in the community with appropriate supports rather than in an institution. And that was very successful. And so a follow-up study then focused on a subgroup of people living in the community but who had difficulties sustaining a stable living in the community. And the nature of the problems, this is just a little bit about the history developed by Stein and Test in Wisconsin, the original program, what was renamed to the Program for Assertive Community Treatment, and then it's typically called Assertive Community Treatment, or ACT, although it goes by many other names, continuous treatment teams and the like. So getting back to the rationale, there's a subgroup of individuals who tended not to access community mental health services, and hence were prone to frequent relapses and rehospitalization, at least partly related to not attending to medication, which you know is potent at preventing relapses and rehospitalization, but also in terms of the inability to manage their lives in many other spheres, whether it was housing, legal interactions, problems with family members or landlords and the like. These were people who were not getting services. The services were not coming out to them in the community. And so they became known, especially in the 70s and the 80s, as the so-called revolving door patient or a client population. In other words, they were revolving in and out of psychiatric hospitals for treatment of acute exacerbations. And the basic philosophy of the ACT program was, well, if you can't get somebody to come into the clinic to get these services, why don't we just bring these services out to them where they live in the community? I mean, a surprisingly refreshing, kind of a common sense idea. Of course, this is not a field that has a great abundance of common sense, so we always welcome it when we see it. Although it's actually an observation that in many places has had an effect on case management services as routinely provided, even outside the context of ACT services, although that impact has varied from place to place. So the idea was, let's deliver the services to those people in the community where they can access them. And then there were certain practical considerations. If you're going to do that, you're going to need to have somewhat lower ratios in terms of the number of clinicians or case managers for each client. You need to work collaboratively in terms of making sure that people's needs were being met. And so a new approach to configuring or providing psychiatric services was developed by the ACT model. And in fact, that's the way I look at ACT, is that ACT is not a rehabilitation approach itself. It's a different way of configuring services for a particular subset of individuals who don't access services the way they're routinely configured in terms of going to local community mental health centers. So the core defining elements of ACT include the lower case manager or clinician to client ratio. Typically 1 to 10 is the gold standard that we're looking for. And I would say in most typical community mental health center settings, the ratio of number of clients to case managers is somewhere in the neighborhood of 20 or 30 to 1. I do understand it goes even higher in some places, like 50 to 1 or even more than that. But I think when you look at what we define as a clinical case management or a strengths-based case management, once you go much over 30, it becomes hard to do those, or you have to divert attentions to a subgroup of more needy people. I mean, that's what most people would say in the field. So you have a more intensive ratio or more intensive services. The majority of services are provided in people's natural environments rather than at the clinic, for the practical reason that people aren't coming into the clinic to get those services. Typically, somewhere in the neighborhood of 60 to 80% of services are provided out in the field, in natural settings, like somebody's home, a park, a restaurant, any of those type of things, a family member's home. A third principle is 24-hour coverage. In other words, full responsibility for the consumer. Now, there are states that have been implementing ACT programs where sometimes they modify this. And so what they'll have is, for example, special emergency teams that are available at certain off hours in place of the ACT team. And that is a deviation from the original ACT model. To make that work, it's probably not completely optimal, but to make it work, those emergency services need to have close coordination with ACT team members. They need to have plans in terms of how to respond to the needs of consumers served on those ACT teams. But 24-hour coverage was certainly part of the original ACT model and still part of many of the ACT models, with different team members covering certain off hours and taking turns doing that. The original ACT model actually involved the team having control over discharge from the hospital, which is not something that's been replicated in most follow-up studies. Another unique characteristic of the ACT program is shared caseloads. Rather than having a clinician responsible for a set number of clients, they share responsibility for the overall team. And the thinking behind this is that it promotes collaboration between different case managers or clinicians. Also, it decreases some of the potential for burnout in terms of that strong sense of responsibility when you have one person with a very severe psychiatric illness who is your so-called responsibility. And there is actually a little bit of research that's looked at and shown that shared caseloads are in fact associated with lower rates of burnout. The majority of services on ACT teams are provided directly by the ACT team members. That doesn't mean that services can't be provided by another vendor if they're really not available on the team. But the basic philosophy is the direct provision, and that's thought to be more effective because the team members have relationships with the consumers, and it's harder to connect people to other vendors, other service providers, when those consumers don't have relationships, especially people with severe and persistent mental illness. And another defining characteristic of ACT was time-unlimited services. Now, the way this came about is that the original study done by Stein and Test, the original study of ACT, comparing ACT on an outpatient basis with standard case management on an outpatient basis, provided the intervention for a 1.5-year period and then withdrew it and saw what happened. And what happened after 1.5 years was that there was an increase in rehospitalizations and the deterioration in outcomes. And so that led to provision of time-unlimited ACT services as a core feature. I think pretty much everyone in the field now looks at that as not a core ingredient of ACT. In fact, practically all ACT teams have very specific criteria for people graduating off of ACT teams and methods for doing that in a smooth and non-psychologically traumatizing way. That it does make sense for people to be able to transition off to lower intensity services. And that when that's done in a thoughtful and planful way, outcomes are very good. You don't get high rates of relapse or anything like that.